guys, welcome back to another episode of my nursing vlogs and podcasts. Today is another day and another topic. Last time I talked about medications that we can give as painkillers for our patients who are in pain, and I mentioned a little bit about epidural analgesia, but I want to expand more on this painkiller. So we're gonna talk about indications, benefits, contraindications, side effects, toxicity symptoms, nursing management, monitoring, possible clinical signs of rising epidural block, epidural catheter removals. It's very important to learn about this, especially if you will be assigned in a surgical ward, and especially if it's a gastro ward. A lot of patients who had abdominal big surgeries, sometimes they come out with epidural analgesia, and basically there's a bag of painkillers and a little bit of opioid in a bag inside a machine, and there's like a catheter from the bag connected to the back directly into the epidural space, which is near the spinal area. So that's why it's very critical to know about all this stuff. It's something that we really need to take seriously, because if we don't assess it properly, it could potentially cause severe complications. And if you're the nurse looking after the patient with an epidural, of course there will be a lot of day techs or incident reports. So in order to prevent that, it's good to watch the whole episode of this vlog. For the indications, this is like scenarios where they would consider starting an epidural analgesia for a patient. So first is upper and lower gastrointestinal surgeries. Second is thoracic. Third is vascular. Fourth is orthopedic lower limb. 5 is urological. And 6 gynecological. A lot of people who gave birth, sometimes they would have epidural. What are the benefits of this? First is improved respiratory function. It's basically just blocking the pain signals around the spinal nerves in the epidural space. Whereas with the opioids, it's systemic. We give it through the venous system. It circulates around the body, which depresses the respiratory system. It causes constipation as well, because basically it just slows down the whole body. And the second benefit is decreased in cardiovascular workload and complications. Third is increased mobility and minimizes the risk of DVT or deep vein thrombosis. I've noticed a lot of patients who had epidural, they're not drowsy. They usually can be mobile. They can tolerate the pain because the pain is really well controlled. And then low risk of slow gastric motility, because again, the opioid slows down the body, and low risk of opioid side effects and decreased length of stay. They are not really restricted with the pain when mobilizing, so it's easier for them to be walking around and getting better day by day. Contraindications are local or systemic sepsis. So there is a risk of meningitis if a patient is having sepsis. Coagulation disorders, they are high risk of having hematoma if they have already coagulation problems. Obesity, spinal deformity, or difficult anatomy. Patients who are obese because of increased risk of accidental dural puncture compared to patients with normal BMI. Spinal deformity is one of the contraindications as well, because of course it's difficult to hit the right target if there's a deformity. The usual medication that we use for epidural in the ward is fentanyl 2 mics per ml plus bupivacaine 0.1%. Bupivacaine is like a local anesthesia that works in the nerves. So it's a combination of opioid and local anesthesia. Let's move on to the systemic toxicity symptoms of the epidural analgesia. So these are the things that you need to watch out for if you want to assess if patient is having a good amount or if they're having too much already of this medication. So in the mild area, there's lightheadedness. Number 2 is numbness around the tongue. 3 is tinnitus. 4 is metallic taste, and 5 is nausea. So sometimes if you have a patient who is like that, just assess the pain, and if the pain is getting better, a lot of the nurses are trained to wean it down, like lower down the dose per hour. And then there's moderate, which is confusion, slurred speech, and muscle twitching. And severe is loss of consciousness, convulsions, coma, respiratory arrest, and cardiac arrest. And we don't want to be in that situation. So we have to do something. If it's showing mild symptoms, we have to do something about it already. So what is the treatment with mild to moderate? Number 1 is stop infusion. 2 is give oxygen via face mask. 3 is monitor closely. 4 is call acute pain team and anesthetist. 5 is inform the medical team. And what are the nursing management that we can do while probably waiting for the doctor's review? 1 is check the OBS, of course. That's our number 1 task. Check the pain score, check the sedation score, if they're having nausea and vomiting. Monitor the motor block score, infusion rate or bolus doses given, and then check the catheter site. Motor block score is just basically checking their like motor function on their extremities, or if there's a weakness already on the legs or on the arms. And you also have to monitor the patient every 15 minutes for the first hour, then every hour for the first 24 hours, then 4 hourly as an absolute minimum. A lot of the patients who had surgery, usually they start in recovery, so they are automatically being checked every 15 minutes anyway, and then you have to check it every hour. Then after 24 hours, you can do every 4 hours if there's no concerns. And there's also like a possible clinical signs of a rising epidural block. First is heaviness or numbness in the chest. And if they are having difficulty taking deep breaths, or if they're having hypotension and bradycardia, any heaviness, numbness, or tingling to the arms. Because if it's already affecting the arms, it could mean that the medication is going up, which affects already like the nerves that are associated with our respiratory system and our hands, which is I think above T4. So you know there's like cervical, there's the thoracic and the lumbar parts of the spinal cord. It should just be covering below the T4s. Sometimes in the ward, they have this chart of dermatones, and you can check like what is the affected dermatone, and you will know if it's above T4 or below T4. Sometimes they would use like a cold spray, and you will check every part of the dermatome if they're feeling something or not, to know if it's already affecting the areas above T4. So hard to explain, but I hope you can imagine it with the picture here. And especially when they're having difficulty breathing, I would really stop the infusion and I will call the doctors right away, like it's an urgent case. One of the complications of epidural is epidural hematoma or abscess formation. This is assessed with like a sudden onset or worsening of motor block and or sensory changes which appear in the absence of any recent bolus dose or increase in rate of infusion. And that's why it's important to always check the pain tolerance of the patient. So sometimes if it's like they don't feel anything anymore, like there's no pain at all, then it's a good indication that you can wean it down already, especially if it's on the highest dose every hour, like 10 mils per hour. You can always wean it down to, I believe the lowest is 3 mils per hour if I'm not mistaken, but again it could always be different in every trust. And of course, if there's like any changes with sensory, especially on the hands, it could be a sign as well of having abscess. About the motor block score, 0 means they can move the hip, the knees, and the toes and the feet. 3 is unable to move all of those. And then things to note about this epidural is epidural can only be used 4 days maximum. After 4 days, it should be changed already to maybe tablets or other kind of painkillers. And then the dose is usually 3 to 15 mils per hour actually, not 10. Okay, fine. No need to wean off. You can just stop for an hour and assess the pain before actually removing the catheter. But again, this will always depend with the doctor's order as well. If the line gets disconnected accidentally, don't connect it back. Because when it's open already and then we connect it back, we can potentially introduce bacteria inside the epidural space. And then epidural catheter removal. Number 1 is check drug chart for the last dose of low molecular weight heparin or LMWH. That's actually dalteparin or enoxaparin or clexane. In my old trust, we use clexane, but in my new trust, we use dalteparin. It's basically the same anyway. It should be 12 hours hours before the last dose of that, before you remove it. And then you have to position the patient at a 30-degree angle. It cannot be flat. And then blue tip should be present, because if the blue tip is not there when you remove it, it could have been like cut off inside. It's probably left inside. So you have to make sure that the blue tip is there to make sure that everything has been removed. If there is like a resistance, if you're trying to remove it, don't force it. Just call someone else or get an assistance as well from someone else or from the doctors. Monitor the site every 4 hours for 24 hours. So you always just have to check if it's leaking something or if there's hematoma formation after. Just make sure that you assess it, and if you see something that doesn't look right, speak to staff. That's what they always say in the train. But yeah, it's still applicable in our area. You have to speak to someone or to the doctors if there's something that is not right. But what is important is you check and you assess properly, and you document after. And that's it. Yeah, so it's been a short video for today, but I hope you learned something. I hope this gives you a little bit of confidence to start working as a nurse in the UK. It's not just about preparing for OSCE, it's also about preparing for the real thing, the real nursing stuff that we will actually encounter. That's why I'm doing this, because when I was starting, there were a lot of things that I actually didn't know, and I hope I knew it before actually starting to prepare me so that there's no like culture shock or whatever. So that's why I'm making this. And yeah, so thank you for watching until the end, and I hope you subscribe to my channel. If you appreciate my video, I would appreciate if you comment down below, because it just gives me strength and energy to do more. So thank you so much for watching, and I hope I will see you on the next episode. Bye.